Good afternoon, everyone, and thank you for joining us today. I can't believe it, but this is the last IBD brief session for the year. So thank you, everyone, for being part of our IBD brief session. It's been a great year. Thank you, Dr. Gottlieb, for running the program, and thank you for trusting me to lead it while you're out. It's been a great opportunity, and I thank everyone. And hopefully today we'll have great cases to discuss, and we have a great panel with us, Dr. Jalal, Dr. Levanos, Dr. Wong, and Dr. Fleitz and Dr. Greenstein on virtually. We don't have any pathology, unfortunately, today, but our cases are more medical, surgical, so hopefully we'll have great discussions on that. Just want to remind everyone that this program is funded by Pfizer, and this is today's panelist. And I'll start it off by having Dr. Jalal teach us about therapeutic drug monitoring in IBD.
All right, thank you, Tamara, for having me today. So I was tasked to give you a short hot topic on TDM and IBD. So this is really going to be like a quick overview of the clinical applications of TDM. I'm not looking to start a debate on proactive or reactive monitoring. Okay, we can keep that for later. All right, so plan, pretty standard. We're going to go through definition, indication, benefits, and current uses. So what is TDM? TDM really is a decision-making tool. It is the measurement of the concentration of a specific drug and its antibodies in a patient's bloodstream, usually used when there is a known association between drug concentration and therapeutic effect, but particularly useful when there is no linear drug-response relationship in a medication. When we see TDM, the question is, how do you interpret that result or that you get in your inbox? So it basically depends on dosage history, sampling time in relation to drug dose, patient response, and the desired medicinal targets for the patient we are treating. Indications of TDM are pretty simple, but particularly monitoring compliance, especially in patients who self-inject themselves at home with medications such as adalimumab. It allows individualization of therapy, diagnosing undertreatment of a patient, avoiding toxicity in some cases, but also guiding withdrawal of therapy if we suspect that the patient is not responding to our treatment. Some benefits of TDM during induction include improved clinical outcome in the sense that we reduce primary non-response, secondary loss of response, and most importantly, there is less inappropriate switching out of class for presumed primary non-response. I think as gastroenterologists here, we all know that many of our patients can have superimposed IBS to their IBD, and therefore that can blur the clinical picture. And before we decide that the patient is a primary non-responder and that their IBD is not responding to the medication, we should typically check for levels before switching to a different class or a different medication. TDM also allows improvement of quality of life in the way that it allows a rapid attainment of remission, less steroid exposure for patient, but also less need for combination therapy with immunomodulators if we do TDM early in the course of a new medication. There are a couple of pharmacoeconomic benefits. Increased patient retention on first biologic. We know that first is usually best in terms of biologic for our patients, so hopefully that can allow better retention, reduce need for subsequent dose escalation, and increase potential for subsequent dose de-escalation. There are pharmacokinetic benefits to TDM as well. Most importantly, I would say reduced immunogenicity due to less subtherapeutic drug concentrations in patients. What are the current applications of TDM in IBD? So there is a bit of an established role and use in infliximab and adalimumab, but most therapeutic targets have been established through post-hoc analyses. So we don't have many solid studies that support the use or how to use TDM in IBD. What we do say usually is that we should strive for higher levels in patients with high inflammatory burden, such as patients with internally fistulizing disease, perianal disease, but also acute severe UC. Those are usually the patients which have high disease burden and usually high turnover of the medication and higher clearance. In infliximab, what we do see in the literature is that we recommend at week 2 if someone is measuring levels around 20 to 25. Week 6, we talk about 10 to 15, and then typically week 14, we're looking at 7 to 10. In adalimumab, the levels are different. We're looking at 8 to 12 at week 4. As we all know, those levels are used as guidance. Some patients may need higher level to achieve clinical and endoscopic remission, so to be used as such. What about the other drugs that we use in our toolbox? So looking at ustekinumab and vedolizumab, some assays are available and used in clinical practice. There are no firm recommendations for those drugs, but some signals suggest that week 8 ustekinumab should be above 3, and for vedolizumab, we should strive for levels above 20. The largest analyses of TDM during induction for these drugs come from Unity and Gemini. What about small molecules and TDM? In terms of JAK inhibitors, role is unclear. We really have no clear drug assays for reliable testing. S1Ps, pretty much the same, no role unclear and no data on TDM and S1Ps. What we do know with these medications is that higher doses are usually associated with increased adverse events, particularly negative chronotropic effects with the S1Ps, so to be used accordingly. What are the role of immunomodulators? Just a quick touching on the subject quickly. They do have a couple of benefits when used with our biologics and in terms of TDM. So we're looking at benefits in terms of synergistic effect, increased efficacy of biologics, reduced immunogenicity, and improved drug concentrations in our patients. Mostly we look at thiopurines and methotrexate. Some of the downsides of the use of immunomodulators in IBD are concerns about safety and adverse events, but also increased costs for the patient. So quickly here, we're looking at a graph on the interpretation of results in proactive TDM. So when we talk about proactive TDM, it's usually when we measure level concentrations during induction or remission. So looking at this, we start up here with TDM during or early after TNF induction therapy. Looking at the left, if we have adequate anti-TNF drug concentrations, we can have one of two scenarios. Looking at the left, we see primary non-response, what we define as non-response based on endoscopy, CRP, or imaging. So really, we're saying here a patient who is not responding after adequate dosing of the medication. We would suggest here switching to a different class because this is a mechanistical failure, or going to surgery if there is an indication for surgery. If there is a response, we suggest continuing on maintenance anti-TNF therapy for this patient. Looking at the other side of the graph, right side, if you have undetectable or subtherapeutic anti-TNF concentrations, you can optimize the medication in the way that you increase the dose or reduce the interval. You could also add an immunomodulator to the medication the patient is using. If the patient is symptomatic, despite that, we look at anti-drug antibodies. If they are negative, we can choose to optimize again, increase dose, decrease interval, or add an immunomodulator. If the patient is symptomatic with positive levels, low levels, we can try and optimize, but if the antibody levels are high, we should discontinue therapy in this case. What about results in reactive drug monitoring? So we usually go to reactive TDM when we suspect loss of response, active disease, or intolerance reported by the patient to the medication they are on. Looking at the two first categories here, when we have high or adequate drug levels, it isn't clinically relevant to measure or look at anti-drug antibodies. If the patient is symptomatic despite high or adequate levels of the drug in the blood, we should objectify loss of response and then determine whether we should intensify the drug or switch out of class. If drug levels are low with intermediate or absent antibodies, we should check for compliance, particularly those who use at-home injections, and either increase drug concentrations to achieve higher levels and eliminate anti-drug antibodies. When drug levels are absent with high antibody levels, that is an indication to switch within or out of class for this patient. So really, in summary, TDM is a great tool to help optimize drug use in patients with IBD. It can support decision-making in terms of therapy when we think about switching drugs, discontinuing, or escalating drug doses. There are mixed evidence in terms of actual benefits, so still need some studies to support use of TDM in IBD. Lack of strong studies supporting the use of TDM in ustekinumab and vedolizumab. And we should look at development and commercialization of point-of-care assays that would allow for optimization based on real-time PK information for our patients. And that's it.